Hello and welcome to this first Texas MPN workshop. My name is Ruben Massa and I'm the director of the Mays Cancer Center at UT Health San Antonio MD Anderson. And this meeting has been organized by myself and my good friends and colleagues at MD Anderson, Dr. Naveen Pamaraju and Dr. Serge Verstavchek. And a special shout out to Robin Scherber, who had been initially a key part of the planning for this meeting. She's now taken an important role at Insight and had stepped away from the planning in all transparency for protection of conflict of interest. But she certainly was a driving force in the initial planning, and we're grateful for those efforts. So we come together at really quite an amazing time, a very challenging time. Certainly I'd be amiss not mentioning the challenges that we face really around the world from the devastating effects of COVID. Here in the US, we've had many challenges, both in terms of domestic turmoil and even a terrible storm that we are fortunate spared our colleagues in Houston overnight, but that was a major hurricane. But we come together really in a spirit of tremendous hope. Patients with myeloproliferative neoplasms need our help and efforts to decrease the burden of these diseases. And this meeting was really designed as a workshop for us to come together to celebrate those advances, to really be able to get a chance to interact, to be able to further enhance that communication. Initially planned, of course, as a live meeting, now virtual because of the purpose and the impact of COVID. That said, the transition of this to a virtual meeting has really allowed us to really broaden the participation of many around the world. And we have over 800 and climbing participants in this very important discussion. Now, obviously, pulling off such an event takes many individuals. So first, we want to thank Brandcast. They are a virtual provider. They worked very hard to pull this together in a relatively short amount of time, and they've been dedicated to making this meeting a success. Very thankful to Charlie Grieve and VJHemonc.com. They've been covering the meeting. Charlie's been a great partner in helping us put this together, and the on-demand publishing after the meeting, as well as the online promotion of the meeting. We are very grateful to our colleagues in the pharmaceutical industry who really have partnered with us in this meeting. First, our sponsors at Insight, Dovo Pharmaceuticals, CTI Biopharma, and Pharmacentia, as well as to our exhibitors, and please visit the virtual exhibit hall from Insight, Jazz Pharmaceuticals, Takeda, and the MPN Research Foundation. The activity itself is also supported by educational grants from Constellation, Insight, Cartos, Protagonist, Sierra Oncology, and STEMline. So you can see it's really a coming together of the MPN community, both investigators, clinicians, nurses. I'm sure some expert patients are joining us as well as our colleagues in the pharmaceutical industry. So before I pass it off to my colleague, Dr. Pamaraju, to orient us to today, just to please to be completing your evaluations as you go throughout. We're going to be learning through this process and try to offer the very best meeting we can next year. Naveen.
Well, thank you, Ruben. And on behalf of you and Serge and our organizing committee, I really want to welcome all of you for this very first of its kind meeting. And as Ruben had mentioned to me earlier, this is really the first major meeting in our subfield of MPN during this whole year of unrest and uncertain times. So welcome to all of our colleagues, particularly our European colleagues and those from all around the world who are joining us. Today's events, I personally am very excited about, and I want to orient you to them. So it's a two-day event, today and tomorrow, all online. Today we'll begin with a breakthrough, lovely session on really the inflammation and biology of the MPNs, led by our colleague, Dr. Ron Hoffman, with very nice talks, really the whole spectrum of before MPN, including the so-called CHIP entity, talking about inflammation and all of the various issues surrounding that. There'll be a second module with MPN subtypes, really trying to hammer down polycythemia vera and ET. We'll then move into a third module discussing unmet therapeutic needs in the MPNs, and that'll set us up for Friday's discussions further on that topic. And then finally, we'll have a very nice closeout session on myelofibrosis and sort of the state of JAK inhibitors, but a unique twist will give a separate 10-minute talk for each of the major JAK inhibitors that are in the later stages of development. So you don't want to miss that. We'll have some breaks throughout the day, Ruben, and also we'll have some live panel discussions that I think our viewers will particularly enjoy. Obviously, this is the first of its kind event. We may, and let's expect possibly that we could have technical glitches along the way, so we'll try to work on those together. But with those words, I'd like to turn it over to my colleague and friend, Dr. Serge Verstovsek, to take us into the main session. Serge?
Thank you, Naveen. Thank you, Ruben. It is an amazing pleasure and honor to join everybody together today for this lovely online event. As Naveen said, this is really amazing what technology allows us to do in this difficult time of pandemic. And we also had overnight a hurricane here nearby. So technical challenge apart, we are looking forward to general two-day enjoyment of understanding the myeloproliferative neoplasms and providing us all a venue to go perhaps to some degree back to normal, at least among the friends and colleagues, and discuss these issues that we all care about. And I'm sure that among 800 and plus registered participants, there are many patients that will enjoy our discussions here. So altogether, I hope that we will find it very useful, and it's just a beginning of a long-term relationship that we can continue in this fashion, and perhaps next year even see each other. Hopefully we can see each other here in Texas for the second iteration in the future. So I'd like to thank you all for being here online, and we're going to move on to the first session with Dr. Professor Hoffman, and we are looking to a really exciting 2 days events, and let's move on. Thank you all.
Good morning. I'm Ronald Hoffman. I'm from the Icahn School of Medicine at Mount Sinai in New York. It's my pleasure to be the moderator for the first session in this meeting, which is entitled Pre-MPN, Atypical MPNs, and Inflammation. We have 5 fantastic speakers that deal with some very important questions as it relates to the biology of MPNs. So 2 of the speakers, Anne and Rafael, will talk about one component, which is the genetic component of myeloproliferative neoplasms. And that will provide us with a link to the next talk, which is by Angela, which will deal with the second component that leads to progression and biogenesis of the symptoms and features of the disease, which is inflammation. Following that talk, I will have the opportunity to talk to you about the molecular events and the biology of the feared consequences of these myeloproliferative neoplasms, the blast phase, which is an extremely severe disease associated with limited survival and essentially therapeutic impotence. And then finally, we're going to switch topics, and we're going to have the unique opportunity of one of my colleagues, Nicole Kucine, who's going to tell us about MPNs and her experience in MPNs in a pediatric population. So I think from this session, we should get a good feel for the genetics and also the inflammatory milieu that leads to the symptoms, the phenotype, and essentially the progression of disease in these myeloproliferative disorders that results essentially ultimately in many of these patients developing blast phase. And Nicole will essentially talk to us about a unique subset of these patients, which we have very little information. This will be followed by a half an hour of discussion, which hopefully will be very lively and will be pursued as a Zoom session. So thank you for attending this session, and I look forward to a very vibrant and lively interaction. Our first speaker is Anne Mullally, who's a faculty member at the Dana-Farber Cancer Institute in Boston, Massachusetts. And Anne will talk to us about genetic biology of MPNs, what's new.
So I'd like to thank Ruben and Naveen for giving me the opportunity to speak at this meeting, and indeed all the organizers. And I've been given the title of Genetic Biology of MPNs, What's New? So I've decided to focus on really the application of genetics to some cases that I've seen in the clinic. So the alternate title is the application of MPN genetics in the clinic. So with that in mind, we're going to start with a case. So this is a case of a 24-year-old woman who presented with profound thrombocytosis, as you can see here, 1.9 million. She had a mild elevation in white count of 10.4 and a normal hematocrit of approximately 42%. And she was first noted to have thrombocytosis 5 years previously when she was age 19 and had a platelet count of 700,000. Her bone marrow was normal cellular for her age. She had increased megakaryocytes and no fibrosis. So all patients who come to Dana-Farber with MPN or indeed with any hematological malignancy have a next generation sequencing panel. It's an in-house panel that we run. It has approximately 100 genes that have ever been described to be mutated in any kind of blood disorder or blood cancer. And so she had that performed off of her bone marrow and was found to have a single gene mutation in JAK2, the JAK2 V617F mutation, with a variant allele fraction of 21%. She had a normal karyotype. So her diagnosis is JAK2 mutant essential thrombocytosis. And in addition to aspirin, she was treated with pegylated interferon alpha 2A or Pegasus. And the reasons underlying this was her very markedly elevated platelet count greater than 1.5 million. And she had neurological symptoms despite being on aspirin. And then with her young age, we elected to treat her with pegylated interferon. So what I want to talk about now is sort of molecular genetics and interferon, and talk about some unpublished work from ourselves and others, sort of helping us to understand which patients respond best and who have resistance to interferon. So this is a study that we did in collaboration with Dr. Hans Hasselbach, Dr. Trine Knudsen, Dr. Viv Skov in Denmark, and again with Dr. Coleman Lindsley on the genomics end at Dana-Farber. And so Dr. Hasselbach has run the DALIA trial, which is a randomized phase 3 trial of interferon versus hydroxyurea. And we collaborated with Hans to perform detailed molecular genetic analysis of this trial to try to understand, as I said, molecular predictors of response and resistance to interferon. So this is the baseline genomics on the 202 patients that were enrolled in the trial. As you can see, the majority of patients had polycythemia vera or ET. There were a small number of patients who had pre-fibrotic MF or myelofibrosis. Here we're looking at their MPN driver mutation, JAK2, CALR, or MPL. As you can see, regardless of their diagnosis, these mutations tend to be strongly mutually exclusive. In this platform, we're also able to identify patients who have uniparental disomy at 9p, and that's where JAK2 is located. And so therefore we can distinguish homozygous from heterozygous mutant patients. We also can measure the variant allele fraction, and red is a higher fraction and blue is a lower percentage. So you can see there's a correlation between having 9p UPD and high VAF, as you would expect because these patients are homozygous for the JAK2 mutation. And then we looked at concomitant mutations in TED2, DNMT3A, SXL1, those were the most common. And then we listed all other mutations in a single category here. And one of the interesting findings from this study is that we found difference in the molecular response in JAK2 mutant patients as compared to CALR mutant patients. And this was at a 24-month time point. So we ran this next generation sequencing panel. It's very similar to our in-house panel, so approximately 100 genes. We ran it at baseline or the 0 time point and then also at 24 months. And we correlated this with clinical responses. And what I'm showing you here on the left is the JAK2 mutant group. So we're looking at those who achieved a complete remission versus those who did not. And CR was defined based on ELN criteria. And then on the y-axis, we're looking at the variant allele fraction at the 2 time points, 0 and 24 24 months. So what you can see in the JAK2 mutant group is that there's a significant reduction in the JAK2 variant allele fraction over time, from a mean of 28 to 8%, in the group that achieved a CR. But in the group that did not achieve a CR, this reduction is not as significant, so 34% to 23%. In contrast, if you look at the CALR mutant group, we do not see this same finding. So regardless of whether you achieved complete remission or not, there was no significant reduction in the variant allele fraction for mutant CALR, so 16 to 12 in the CR group and 20 to 16 in the no CR group. So this indicates that in JAK2 mutant MPNs, the hematological and molecular responses appear to track together, whereas this is not the case in CALR mutant MPN. And it also seems to suggest that JAK2 mutant patients are more sensitive at the molecular level to interferon as compared to CALR mutant patients. This finding has also been independently observed and is also unpublished by the group of Dr. Isabella Plot at Bejar in Paris in France. And Isabella was kind enough to share these slides with me for this presentation. So this is an observational study of patients treated on interferon in France. There were 48 patients on whom this analysis was performed. As you can see, mostly ET and PV patients. 8% had myelofibrosis, approximately 2/3 had JAK2 mutations, 29% calreticulin, and then 4% MPL. And so what Isabel and her colleagues did was they were trying to understand a similar question to us, but they went about it in a different way. So they isolated different fractions of cells from patients, mature granulocytes and platelets, but also immature stem and progenitor cells, and then sequentially monitored the variant allele fraction over time, collecting samples every 4 months and following the patients for 4 years. And this is just an aggregated analysis of one aspect of this. So here we're looking at the immature progenitors. So these are CD34 positive, CD38 negative, CD90 positive. So enriched for stem cells. And we're looking at the allelic burden on the y-axis and then time in days on the x-axis. So 1,000 days here, so approximately 3 years at this time point. And this is primarily a comparison between JAK2 and CALR mutant patients, as the number of MPL patients was small. And the JAK2 is in green, and as you can see, you do see this reduction in JAK2 allelic burden within this immature progenitor population enriched for stem cells over time, really, over the first sort of 2.5 years, and then it plateaus. This is in contrast to the calreticulin mutant patients, where you don't see this reduction, and indeed it appears that it increases gradually over time. So again, this is an independent set of data suggesting that interferon targets the progenitor and stem and progenitor cell more efficiently in JAK2 mutant MPN as compared to CALR mutant MPN. So we'll go on to a second case now to illustrate another point. This is a case of a 45-year-old woman who presented with abdominal pain and early satiety. And she had mild thrombocytosis, but had profound marked intra-abdominal thrombosis. So she had thrombosis of her portal vein, superior mesenteric vein, splenic vein, and had splenomegaly, and indeed had portal hypertension. And this was her first presentation. Her bone marrow cellularity was normal for her age, increased megakaryocytes, and grade 1 reticular fibrosis. On her NGS sequencing panel, she had a JAK2 mutation, 21%, but also had a concomitant loss of function TET2 mutation at 41% variant allele fraction, normal karyotype. So her diagnosis was ET, and she had co-mutant JAK2 TET2 mutant disease. And we treated her with anticoagulation and cytoreduction in view of her marked thrombosis. So can we say anything about the molecular genetics and how they impact prognosis in this patient? So I want to highlight a article that literally is just hot off the press, so definitely falls in the category of what's new. And this is work from Dr. Jean-Jacques Kalagin and his group in France, and indeed also some Italian collaborators, Dr. Passamonti. So what this group did was they looked specifically at patients who had MPN and splenic vein thrombosis and wanted to determine what was the impact of molecular genetics, and did molecular genetics play any role in driving adverse outcomes. So there were approximately 195 patients who had MPN and splenic vein thrombosis, and of that 195, there were 80 on whom they had next-generation sequencing data, and they used a 36-gene panel to perform this molecular profiling. Of the 80 patients, about half of them had just a sole MPN driver mutation, and then half had concomitant mutations. So this is some of the data from the study. So a few things to draw your attention to here. The majority of the patients had PV and ET. Small number had myelofibrosis. If we look at the driver mutation, there's three groups. There's a JAK2 mutant group with an allelic burden less than 50%, JAK2 mutant group with allelic burden greater than 50%, and then the calreticulin mutant group. So right away, you'll see that the JAK2 mutation is much more common in these patients with splenic vein thrombosis than the calreticulin mutation. And indeed, it's much more common to have a JAK2 allelic burden less than 50%. And this is consistent with what has been published previously. So these patients typically with intra-abdominal thrombosis tend to be young patients, they tend to be female, and they tend to have JAK2 as much more frequently than CALR, and they tend to have low JAK2 allelic burdens. So then if we look at what were the concomitant mutations that were detected, they looked at epigenetic mutations. TET2 was the most common co-occurring mutation, also found mutations in DNMP3A and some of the IDH genes. And then they put the group chromatin and spliceosomal mutations together. So these were ASXL1, EZH2, or any spliceosomal gene mutation. And then there was a group of others, which included P53 mutations shown here. And so then they wanted to look at, as I said, what were the predictors of adverse outcome. And the primary outcomes that they looked at in this study were three things. One, the development of fibrosis. Two, the development of leukemia. And three, death. And they built a model and determined the odds ratio for various different factors that might be associated with increased risk of the development of one of these primary outcomes. And three main factors came out. The first was having a high JAK2 allelic burden, greater than 50%, odds ratio here of almost 15. This is consistent with previously published data showing that high allelic burden is associated with fibrotic transformation, and also with data in mice that shows the more highly you express mutant JAK2, the more fibrosis you engender. The other thing that came out was the presence of additional mutation, odds ratio of almost 6, and in particular, this was driven by the presence of chromatin or spliceosomal mutations. So these mutations seem to drive out these adverse primary outcomes. Again, this is consistent with other data in the absence of splenic vein thrombosis showing that spliceosomal mutations and chromatin in particular, ASXL1, are associated with more adverse outcomes. So then finally, we'll move on to the last illustrative case. This is a case of a 66-year-old man who presented with fatigue, not much else in the way of symptoms, had a low MPN 10 score, had profound leukocytosis, left shifted but no circulating blasts, had an elevated LDH, had mild splenomegaly on CT, but no palpable splenomegaly, had a hypercellular bone marrow, marked increased megakaryocytes, grade 2 reticulin fibrosis, and then on his NGS sequencing had 3 separate mutations, a JAK2 mutation, an ASXL1 mutation, and a KRAS mutation, had a normal karyotype. So his diagnosis was myelofibrosis with 3 concomitant mutations, and by his prognostic scores, he was intermediate 2 by DIPS plus and intermediate risk by MIPS plus. So he was treated with cytoreduction with just hydroxyurea since he didn't have much in the way of symptoms, didn't have marked splenomegaly, and then was referred for consideration of allogeneic stem cell transplantation. So I want to focus in on the fact that ASXL1 mutations are associated, are a high molecular risk mutation in myelofibrosis. And they are associated with several adverse outcomes. They're the most common mutation, have been reported to be the most common mutation acquired on ruxolitinib treatment. They're also associated with adverse outcome in the setting of allogeneic stem cell transplantation. And indeed, we know that the presence of 3 or more mutations based on published data is associated with a shorter time to treatment failure to ruxolitinib. So these were the factors that came to play in referring this patient for consideration for allogeneic stem cell transplantation. There's also data that the presence of KRAS mutations is associated with a higher risk of progression to leukemia. And so again, supporting this reason for referral. So currently we have no therapies to target ASXL1 or indeed KRAS. And so we need new treatments. And so I wanted to highlight a recent study that has actually come up with some ideas about how you might target at least the megakaryocytes in myelofibrosis in a way that is agnostic to whatever mutations the patient might have. So this is the study, it came out in May of this year from Beth Pasilla and Adam Mead and multiple collaborators, primarily at Oxford University in England. And they focused on the single cell analyses. And so in this study, they had 15 patients with myelofibrosis, 13 of whom had a JAK2 mutation and 2 had a CALR mutation. And they had 6 healthy donors, and they performed single cell whole transcriptomic analysis. And this is a dimensionality reduction plot just showing the distribution of the cells based on the transcriptome of these single cells. So this is both the healthy donors and the patients with myelofibrosis, they're single cells, looking at where they are positioned. So here's the stem cells here, erythroid cells here, megakaryocytes here, myeloid cells here, and small fraction of lymphoid cells down here. Then if you look at where are the healthy donor cells and where are the MF cells? So the healthy donor cells are in blue and the MF cells are in this maroon color. And you can see that they don't superimpose. So you can see the majority of the megakaryocytic population is from myelofibrosis, indicating that there's aberrant megakaryopoiesis within myelofibrosis patients. And then they looked at what molecules are expressed within this megakaryocytic compartment, and in particular, they wanted to focus on cell surface molecules with the idea that these could be potentially targeted. So this is integrin 2B, which is CD41, which is often how we identify megakaryocytes using flow cytometry. And then they also focused on this molecule G6B, which is known to be expressed in normal megakaryocytes, and again is a cell surface receptor. And you can see they found that it was highly expressed within the megakaryocytes cells here, but also present in other cells, as you can see here. So then they went on to focus in on G6B as a potential therapeutic target. So this is flow cytometry data just looking at the expression of G6B on the surface of CD34 positive cells, so progenitor cells in healthy donors versus patients with myelofibrosis. And as you can see, there's a significant increase in expression in patients with myelofibrosis. Then they wanted to see if there's any enrichment of G6B positive cells in JAK2 mutant cells to see if it was specific to the mutant cells. And the way they did this is they pooled cells from healthy donors and patients with myelofibrosis, and then they sorted them based on what was G6B positive or what was G6B negative, and then they quantified JAK2, V6 and 7F expression using qPCR. And again, you can see that the G6B positive cells are enriched for the expression of mutant JAK2, V6 and 7F, suggesting that these cells are enriched in the malignant megakaryocytes, and these megakaryocytes from the MF fraction. And then finally, they went on to develop an antibody to target G6B. So as I told you, G6B in normal hematopoiesis is expressed on mature megakaryocytes, which don't express CD34. But in the context of myelofibrosis, you can see co-expression of CD34 and G6B. So they exploited this as a way to sort of discriminate MF megakaryocytes from normal healthy megakaryocytes, and developed a bispecific antibody that binds to these two cell surface markers. And this is just a proof of concept here in a cell line. This is a megakaryocytic cell line that's JAK2 mutant, to demonstrate that this bispecific antibody is bound and internalized. So what you're looking at here is fluorescence. The higher the intracellular fluorescence, the more internalization of the antibody. So the bispecific antibody is in orange, the isotype is in gray, and you can see you have this increased intracellular fluorescence indicating that it's internalized. And then if you treat with an endocytosis inhibitor, either dinosaur or pit stop, this is inhibited. So this is a novel approach to try to target the megakaryocytes, which are thought to be the key cellular driver of myelofibrotic transformation, and think about ways that they could be targeted using immunological approaches such as this. And this would be a way to kill these cells that would be agnostic to whatever mutations they had underlying the myelofibrosis. So I'll end there and just acknowledge the members of my lab and my collaborators who I've already mentioned, and then finally all of the funding agencies. So thank you very much.
Our next speaker will be Rafael Bejar, who's at University of California at San Diego Health Sciences Center in La Jolla, California. And Rafael is going to speak to us about a particularly important topic, which is clonal hematopoiesis of indeterminate potential and myeloproliferative neoplasms. Rafael, thank you for joining us.
Hi, this is Rafael Bejar. I'll be speaking today about CHIP and its implications for myeloproliferative neoplasms. So I'll start by talking a little bit about what clonal hematopoiesis is and when we need to worry about it. And in particular, when we find clonal hematopoiesis with MPN gene mutations, is that really truly clonal hematopoiesis of indeterminate potential, or is it really clonal hematopoiesis of oncogenic potential? And then I'll talk a little bit more broadly about the implications of CHIP when we find it associated with MPN gene mutations that maybe go beyond its neoplastic consequences. And at the end, if the time allows, I'll talk a little bit about targeting CHIP for therapeutic benefit. So let's start by talking about clonal hematopoiesis itself. So clonal hematopoiesis is defined pretty simply. It's a detectable collection of cells that have shared ancestry, and that shared ancestry is inferred by the fact that they have a common somatic mutation. Now, some of these clones that we identify maybe are of no clinical consequence. They're either going to disappear, or they maybe never turn into anything that's clinically significant. But occasionally, one of those will evolve and move into something that we need to worry about in a clinical sense. So here's another example of that during our lifetime, cells can develop mutations that allow them to expand in some detectable way. Now, if those occur in non-stem cell populations, those might be extinguished automatically, or if they are recognized by the immune system, they might be pruned by the immune surveillance. And occasionally, genetic drift will allow a detectable clone to emerge, but maybe doesn't necessarily have a selective advantage and may not persist. What we're going to be particularly worried about are those pre-malignant lesions, those mutations in genes that are known to cause cancer that can occur well before any symptomatic or phenotypic findings suggest that that mutation is a problem. And during that evolution might eventually turn into a form of malignancy that we need to be worried about. So this is the way that I view it. You have a hematopoietic stem cell that has this unique capacity to self-renew, and this is balanced with its ability to differentiate into mature normal blood cells. Now, if these stem cells acquire a somatic mutation that alters that balance, so now they have a greater propensity to expand or grow in size, it doesn't necessarily mean that that individual has a disease. It depends on what that mutation that affected the stem cell fitness does to the differentiating cells. And it's possible that it does very little to the differentiating cells. In such case, there will be no clinical phenotype, and this would be clonal hematopoiesis of indeterminate potential. Now, alternatively, if that mutation leads to expansion of the differentiated cell compartment, then we would call that a myeloproliferative neoplasm. If instead it impaired differentiation, maybe that's a form of early MDS. Now, this clonal process is ongoing, and you get further clonal evolution and selection for further mutations that can further impair hematopoiesis. And if this occurs, then we may see more advanced forms of disease like advanced MDS or myelofibrosis, and ultimately, when there's an accumulation of blasts in the bone marrow, we just call it secondary AML. So let's start by showing you some examples of clonal hematopoiesis of indeterminate potential. This is originally described by looking at patients who were enrolled in the Cancer Genome Atlas. The purpose of this study was to sequence tumors, identify driver mutations, and compare them to mutations that might or might not be in the germline. So those mutations that were unique to the tumor were associated with that cancer and are therefore considered oncogenic. What the authors of this study decided to do was flip this paradigm and instead look for mutations that are only in that germline blood sample. And if there are mutations that are only in that blood and not in the tumor, then those can be considered somatic mutations in the hematopoietic compartment. And when they did this, they found a wide variety of genes that were mutated in the blood of these patients who were not known to have hematologic disorders. The most frequent were DNMT3A, TET2, and ASXL1, but you can see actually the third most common in this patient population was JAK2 itself. There was a very strong age dependence, with older patients being much more likely to harbor this phenomenon. So these findings were confirmed in larger studies that examined persons who were participating in genome-wide association screens, and they found with a very strong age dependence that somatic mutations in the hematopoietic compartment were common, and it could be identified in up to 15% or more of patients in their 70s or 80s. And again, the most commonly mutated genes were those genes that we saw in that earlier study, namely DNMT3A, TET2, ASXL1, and again, JAK2 making the top 5 in both of these studies as well. So if we look at the mutational spectrum of myeloid malignancies like MDS, AML, and MPN, we find that those genes that are frequent in CHIP are among the most frequently mutated genes in these disorders as well. They're at the top of that frequency list. And in particular, for MPNs, of course, JAK2 is one of the most frequently mutated genes, being the defining gene in several disorders. If we look more closely at the pattern of mutation in different disease types, you can find that there are some mutations that are very unique to disease states. So things like FLT3, NPM1, the IDH genes, for example, are very common in AML, U2AF1, RUNX1, and so on become more common in MDS than they are in persons with clonal hematopoiesis. But again, those most commonly mutated genes in these diseases, the DNMT3As, TET2, ASXL1, and JAK2, are very frequently mutated in persons who have no overt hematologic malignancy. Now, does not mean that those patients have no risk of developing hematologic malignancy or no increased risk. Not exactly. They do have a fairly high relative risk of developing a hematologic malignancy in the future, but their absolute risk is relatively low, estimated to be about 1% per year. And if we do look at the varying allele frequency, which is a marker of the clonal burden of disease, we do see that patients who have higher clonal burden or higher variant allele frequency have a higher risk of progression to a hematologic malignancy. So there is an association with the amount of mutational clone that they have on board, but many patients who have very large clones don't seem to progress in short follow-up periods. If we use even more sensitive techniques, we can identify clonal hematopoiesis in almost anyone in their 50s and 60s. In this study that used an error-corrected next-generation sequencing approach, they identified small clones in 95% of the individuals that they examined. Most of the mutations were in DNMT3A, followed by TET2, and as you can see, none of these individuals had mutations in JAK2, suggesting that it's fairly rare at a very small level like this, meaning potentially that if a JAK2 mutation is identified, that it has greater oncogenic potential than these more common low-level mutations that were identified in this study. Now, a very clever study that examined the rate of JAK2 V16F mutations in the general population took advantage of a test that people were using to examine their genetic ancestry or their genetic associations with health. This is the 23andMe test, where patients spit in a tube and send it to the company for variant analysis. Now, interestingly, the company had included a probe for the JAK2 V16F mutation. So the first thing that the researchers did is they collected a large number of patients with MPNs and asked them to send in their spit test to prove that the JAK2 V16F mutation could be detected this way. And they found that for those patients known to have the mutation, that it could be detected in the majority of cases. And those patients who were believed to be V16F negative, that mutation was not picked up in the majority of cases. So it seemed to be like a relatively good assay for this. Then they went back and examined the tens of thousands of people who had submitted their samples and found that a large fraction, 0.2% of this population that was unselected for hematologic malignancies, did indeed have a JAK2 V16F mutation, and that there was a very strong age dependence. And I think what's striking is that many of these individuals have relatively high varying allele frequencies as detected by this test, suggesting that they were living with this mutation and not necessarily manifesting overt signs of disease. So what we don't know about these patients is whether they went on to develop a frank hematologic malignancy, whether they did develop an MPN, and how long that might have taken. Other studies have examined this idea that patients with non-diagnostic evaluations, but who have some signs and symptoms of the disease, might have different risks of progression depending on whether they have underlying mutations. So in this study by Malkovati et al., they took individuals who were suspected of having MDS or another hematologic malignancy, did a bone marrow biopsy, and then examined those individuals that had a non-diagnostic biopsy. Those patients who had no mutations on a broad array of genes were very unlikely to progress to a frank hematologic malignancy. However, if patients had one mutation, they had about a 40% risk of progression. 2 mutations was about 60%, and 3 or more mutations, that risk was closer to 80%. And when you look at the Kaplan-Meier curves for progression, you see that patients who had the typical CHIP mutations like DNMT3A, TET2, or ASXL1 had an intermediate risk of progression that approached 50% in 4 years. But patients who had splicing factor mutations, runxone mutations, or 2 or more mutations had a very high rate of progression, and this included individuals that had mutations in JAK2. So JAK2 mutations seem to predict prognosis, or at least development of progression, in these individuals with non-diagnostic evaluations. Now, other studies have looked at this in retrospect. They've taken individuals who have been diagnosed with a JAK2 mutant MPN and then looked back to see how long ago can we find evidence of that clone in these patients before they were diagnosed. And in this study of a relatively small number of patients, identified a small clone in the vast majority of individuals, suggesting that JAK2 V16F mutations precede the actual development of a myeloproliferative neoplasm by several years, in this case estimated somewhere between 5 and 15 years. In a more balanced study that looked at a general population of individuals who were then screened for these mutations, in this particular study they identified 63 persons who had mutations of one of these genes. 30 of them met criteria for an MPN at that time, and 33 were considered to be undiagnosed. Essentially, they didn't have criteria for MPN at that time. They then followed these patients and collected subsequent samples 5 to 9 years later and found that the vast majority of individuals who had these mutations earlier were then subsequently going to develop a myeloproliferative neoplasm. Only 8 individuals that were diagnosed as having one of these mutations, in this particular case JAK2 V16F, went on to remain phenotypically normal at follow-up 5 to 9 years later. And if we look at the varying allele frequencies of these individuals that did go on to develop an MPN, you can see that they started with fairly low varying allele frequencies in kind of the 3 to 9% range, and these increased slowly with time, but it wasn't a very dramatic increase by the time they were diagnosed. However, those individuals who did not go on to develop an MPN had a very flat varying allele frequency curve over the follow-up period here. So it suggests that most patients are likely to progress, but some may not, and we don't necessarily know what factors predict that eventual evolution. A similar study was done with an even larger patient population. Nearly 20,000 Danish persons were screened, both for JAK2 mutations and CALR mutations, in this case using a very sensitive droplet PCR technique that could identify VAFs well below 1%. 3% of individuals had JAK2 V16F mutations in this case, but only 0.16% of these individuals had CALR mutations, suggesting that CALR mutations are much less common in this kind of undiagnosed asymptomatic individual. Now, the vast majority of these individuals did not have an MPN diagnosis, but if you look closely, 13% of them would have met criteria had they come to clinical attention. The CALR patients were much more likely to meet the MPN criteria, again suggesting a shortened latency between the development of a CALR mutation and the development of a frank MPN. When looked as a whole, however, I will point out that 40% of these individuals had normal blood counts, and 50% of them had some elevation in their blood counts that didn't quite meet criteria for a myeloproliferative neoplasm. So there was some hint that these mutations were not silent in these individuals, that they were increasing the blood counts to some extent. And importantly, the venous thromboembolism rate in the JAK2 V16F mutants was substantially higher than in the general population, and this was independent of whether those patients were found to have an MPN or whether they had the mutation with a phenotypically normal clinical evaluation. The same phenomenon is also true in patients suspected of having CMML. So this is a study by Catherine Cargo and her group that looked at patients referred for evaluation of monocytosis. Now, a good proportion of these patients did in fact have CMML, and their sequencing profile is consistent with that, with a high frequency of TET2, SRSF2, and ASXL1 mutations. But many of the individuals who had a non-diagnostic evaluation, meaning no CMML criteria were met, these individuals had a high frequency of mutations as well, and the mutation profile looked very similar to that as in the patients who did have CMML, with the exception of a fraction of individuals who had no mutations whatsoever. When we look at the outcomes of patients based on their mutational status, you can see that the CMML patients, shown here in blue, have survival that is a little bit better than patients who are not diagnosed with CMML but have these somatic mutations, but it's not statistically significantly different. However, if these individuals with monocytosis don't have any mutations, then their survival is quite good and very different than that from those patients with mutations or those patients with CMML. Again, suggesting that mutations that precede the overt characterization of disease are very important, as they may indicate a latent disease state. So now I want to talk about the impact of clonal hematopoiesis on other factors besides their oncogenic potential, on their risk of progressing to a frank hematologic malignancy. So one of the early indications in patients with CHIP that was associated with mortality had to do with their cardiovascular mortality. Especially the older individuals had a higher rate of cardiovascular disease and ischemic stroke, independent of whether they went on to develop a hematologic malignancy. Now, this has been validated now in several studies. So in this study, for example, they found that the effect of having clonal hematopoiesis was quite significant, and in fact was similar to that of having an elevated cholesterol or hypertension. But when we look at which genes define clonal hematopoiesis, we find that DNMT3A, TET2, and ASXL1 all have a hazard ratio that's close to 2. However, when we look at JAK2 mutations, we find that the risk is substantially higher. Now, while JAK2 mutations were much less common in this broad patient population, their risk in this non-myeloproliferative neoplasm state seem to be quite high. And this may be in part not just because of its atherogenic potential, but also because of its risk of thrombotic events, as we saw earlier. So what is the link between these mutations and the development of cardiovascular disease? Several animal studies have shown that this is not just a casual observation where patients with clonal hematopoiesis are more likely to have cardiovascular disease for independent reasons. It seems like the clonal hematopoiesis itself is a driver of this accelerated atherogenesis and cardiovascular disease state. And these are studies done with TET2 mutant bone marrow donor cells that then mature into macrophages and monocytes that have a particularly inflammatory phenotype. That is, gene expression arrays demonstrate upregulation of several chemokines, including cytokines like IL-6 and IL-1 beta. I think it's interesting that this was shown in an animal model, again using a TET2 knockout as the bone marrow donor, where they also had increased inflammatory markers, but where this increased atherogenesis associated with CHIP could be prevented by inhibiting the NLRP3 inflammasome, again suggesting another therapeutic approach that didn't necessarily target the mutant clone itself, but targeted some of the inflammatory consequences of that mutation. And our next speaker is going to talk in greater detail about this association between MPN mutations and inflammatory states. Now, one of the things that's difficult to tease apart when we're thinking about JAK2 is the difference between its potentially pro-inflammatory role and its pro-thrombotic role. So this is a very elegant study by Sinai et al. That used a transgenic model using a myeloid-specific promoter, so the JAK2 mutant or wild type was expressed only in the differentiated myeloid cells and did not lead to a myeloproliferative neoplasm phenotype. These mice had normal blood counts, whether or not they carried the JAK2 V16F mutant. However, after myocardial insult, in this case ligation of the LAD, the mice had very different changes in cardiac remodeling with increased fibrosis if they carried the JAK2 V16F mutation. And again, they saw increases in some of these inflammatory cytokines like IL-6 and IL-1 beta that were associated with the presence of this mutation in the mature progeny. So can we do something about this? This is likely going on in our patients as well. Is there something that we can do to target outcomes? And there's a very interesting study, the CANTO study, that looked at inhibition of IL-1 beta using a monoclonal antibody that suggests there may be some mechanism to do this. In this particular study, they examined patients with cardiovascular disease to see if inhibition of IL-1 beta could cause reduction in subsequent cardiovascular events. And it didn't quite meet its primary endpoint, but when they looked more closely at those individuals in the study that had clonal hematopoiesis, whether that were defined by TET2, DNMT3A, or others, they found that the majority of the benefit was accrued in these patients. So these patients had a 64% relative risk reduction with IL-1 beta that was substantially greater than it was for the general population, most of which did not have clonal hematopoiesis. So what other ways might we be able to employ to address the cardiovascular consequences of CHIP, even before we think about the neoplastic progression? Well, several options have been considered that include statins, metformin, which actually can inhibit cytochrome C and lead to reduced oxidative reactive oxygen species. NLRP3 inhibition, as I mentioned, has strong preclinical data. It may also impact the clone fitness. Targeting IL-6 and IL-18 may be less immunosuppressive than IL-1 beta blockade. And finally, there may be consideration for JAK2 inhibition or anticoagulation in JAK2 mutant patients who are at increased risk of consequences of carrying this mutation even before they develop a frank myeloid neoplasm. So I'll summarize. I'll say that CHIP is very prevalent and highly age-dependent. We're likely to identify it in patients that are sequenced for other reasons. But in the right clinical context, certain patterns of mutation can predict disease progression to MPN or MPN MDS like CMML. But even in the absence of this neoplastic progression, MPN-associated CHIP mutations are of clinical significance. They are associated with increased cardiovascular disease and thrombotic events, and are opportunities for us to potentially intervene even before we start thinking about the risk of neoplastic progression. So with that, I'll end and thank my colleagues at UCSD, and will participate in the question and answer session shortly. Thank you.
The next speaker is Angela Fleischman, who's from the University of California at Irvine Health Sciences in Orange County, California. Angela will speak to us about emerging science in myeloproliferative neoplasms, that is the role of inflammation in the disease microenvironment, biology, and outcomes. Angela?
Hi, my name's Angela Fleischman, and I'm a physician scientist at the University of California, Irvine. Today, I'll be discussing the role of inflammation in MPN disease pathogenesis, microenvironment, biology, and outcomes. So the three main points that I'll be going over today are: number one, inflammation as a predisposing factor to acquire MPN, going over observations from epidemiological studies, as well as a little bit of mouse and human studies from my own lab. Secondly, bringing up the possibility that we could leverage inflammatory cytokines to aid in our diagnosis and prognostication of MPN. And then thirdly, briefly touching upon inflammation as a therapeutic target in MPN. Inflammation is high in both MPN patients as well as mouse models. And we know that inflammation causes many of the symptoms associated with MPN, but likely also has a much more deep involvement in MPN pathogenesis and prognosis. A number of years ago, we identified TNF as being elevated in patients with myeloproliferative neoplasms, and interestingly, it correlates with the JAK2 allele burden. A big question about inflammation in MPN is which comes first. We know that the presence of JAK2 mutant cells creates inflammation. However, there's also data to suggest that inflammation may predate the diagnosis of a myeloproliferative neoplasm. There are many observations that suggest that inflammation precedes a myeloproliferative neoplasm. First off, patients with autoimmune diseases have an increased risk of myeloproliferative neoplasms. This suggests that a chronic inflammatory state may increase one's risk of MPN. In addition, acute inflammatory stimuli, such as is encountered with an infection, increases the risk of myeloid malignancies. Interestingly, only cellulitis was associated with a significantly increased risk of MPN. In addition, lifestyle choices such as smoking, which is known to increase inflammation, increases one's risk of myeloproliferative neoplasms. Interestingly, smoking has also been identified as a risk factor in multiple studies assessing clonal hematopoiesis of indeterminate potential, or CHIP. Specifically, there's been a few studies looking at inflammatory bowel disease and clonal hematopoiesis, as well as an MPN. A recent study by the Challen lab identified that patients with ulcerative colitis had an increased risk of CHIP, specifically with DNMT3A and PPM1D mutations. And also a number of years ago, a study investigating patients in an inflammatory bowel disease clinic who had a platelet count above 450 revealed that almost a quarter of them harbored a JAK2 V617F mutation. This highlights that in patients in whom have an elevated platelet count with a known autoimmune or inflammatory condition, it may be important not to just chalk that up to reactive thrombocytosis, but that may possibly implicate a myeloproliferative neoplasm. I thought these two studies were interesting, focusing on a specific type of inflammatory condition, specifically inflammatory bowel disease, and an increased risk of clonal hematopoiesis. Chronic inflammation has significant negative effects on multiple organ systems, including the hematopoietic stem cells. Chronic inflammation is known to lead to inflammation-induced exhaustion of hematopoietic stem cells from repeated cycling of HSC. And one potential mechanism for the way that chronic inflammation may drive the expansion of clonal hematopoiesis, including JAK2 V617F clonal hematopoiesis and subsequent myeloproliferative neoplasm, is in this pictorial. So in this pictorial, one can envision the cells residing in a bone marrow. The pink cells are wild type, the green cells are JAK2 V617F mutant, and the owl is inflammation. If there was a situation of chronic inflammation in which the inflammation specifically targeted the wild type cells, which were vulnerable to the inflammation, and there was a minor clone that was resistant to inflammation, then one can envision over time the wild type vulnerable cells to go away, leading to the selective expansion of the mutant cells at the expense of the wild type cells. And another interesting feature of JAK2 V617F, as well as other CHIP mutations such as TET2, is the presence of the cells themselves exacerbate inflammation. And this in turn may fuel their selective advantage in that they have a selective advantage in the context of inflammation, and the presence of the cells themselves increase inflammation. And interestingly, there's a familial predisposition to acquire MPN, suggesting that the environment in MPN families may be particularly conducive to the selective outgrowth of clones with MPN driver mutations. Amazingly, first-degree relatives of MPN patients have a 4 to 5-fold risk of acquiring a myeloproliferative neoplasms. And in the recently established MyMPN registry, 15% of registrants reported a family member with MPN, and 11% of them reported a family member with another blood cancer. So this brings up the question is, could an increased tendency to have a chronic high inflammatory environment be possibly the underlying feature of families who have a predisposition to acquire MPN? So one could envision if one's bone marrow environment had chronic high inflammation, which was selective for specific clones, such as JAK2 V617F, that engendered resistance to this inflammation, then one would see outgrowth at a higher rate among these families. So to try to get at why MPN patients produce too much inflammatory cytokines, such as TNF, we investigated specifically the monocytes of MPN patients in response to toll-like receptor ligation, specifically TLR4 ligation with LPS. So under normal circumstances, after stimulation of LPS, monocytes produce TNF, and they do this for a period of time, and then with appropriate negative regulatory feedback, they turn off TNF production. So the blue is normal controls, and as expected, at 4 hours following LPS exposure, TNF production peaked, and then over the next day, TNF production went back to normal. But in contrast, in MPN patients, following exposure of LPS, MPN patients continued to make TNF for up to 24 hours following exposure. This suggested to us that there was a defect in the negative regulation of toll-like receptor signaling in MPN patients, and this could possibly be one of the underlying reasons why there's chronic inflammation in MPN. So we focused on IL-10, and IL-10 is important for negative regulation of toll-like receptor signaling in response to LPS. TNF is produced, but IL-10 is also produced, which in turn feeds back to turn off TNF production. So what we did was we stimulated MPN patient monocytes as well as normal controls with LPS plus exogenous IL-10. And as expected, in the normal controls, the addition of IL-10 blunted TNF production, whereas in MPN patients, exogenous TNF was less able to blunt LPS-induced TNF production. This suggests that there is a deficiency in MPN patients to respond appropriately to IL-10. We had the opportunity to utilize a pair of discordant identical twins, one with PV and one without any myeloproliferative neoplasm, to investigate the possibility of whether this persistent TNF production driven by the inability to respond to IL-10 may be present prior to the development of a myeloproliferative neoplasm. And interestingly, we found that just as in the PV patient, her unaffected identical twin had persistent TNF production following LPS stimulation. And not shown here, she also had demonstrated the less of an ability to respond to IL-10. So moving on, we investigated using a JAK2 V617F mouse model the possibility that blocking of IL-10 receptor signaling could enhance the selective advantage of JAK2 V617F mutant cells. So to test this, we did competitive repopulation assays, transplanting at a ratio of 1:1 JAK2 V617F knock-in and wild-type cells into lethally irradiated recipients. After 60 days post-transplant, we began blocking IL-10 receptor with a neutralizing antibody, treating mice weekly, and we followed chimerism following initiation of treatment. And as you can see, in our hands, when we transplant JAK2 V617 knock-in versus wild type, the JAK2 knock-in actually undercompete the wild type, the pink line. However, when we added IL-10 receptor blocking antibody, the selective advantage of JAK2 V617F mutant cells was enhanced. This suggests that blocking of IL-10 receptor and the chronic inflammation which ensues enhances the selective advantage of JAK2 V617F cells. Moving on to more clinical observations as to bringing up the possibility of utilizing cytokines in MPN diagnosis and prognostication. So cytokines have known to be elevated in myeloproliferative neoplasms, in particular in myelofibrosis, for many years. And this study investigated 127 primary myelofibrosis patients with a cytokine panel, asking whether the specific cytokines or a specific cytokine signature could be predictive of prognosis. And in treatment-naive patients, increased levels of IL-8, IL-2 receptor, IL-12, IL-15, and IP-10 were independently predictive of inferior survival. And leukemia-free survival was predicted by IL-10. And interestingly, this was the only cytokine that was associated with 1% or more circulating blasts. This data is appealing in that this brings up the possibility that utilizing cytokine measurements clinically could possibly enhance our ability to prognosticate in patients with myelofibrosis or other myeloproliferative neoplasms. However, at the present time, cytokine analysis is not incorporated into any of the utilized prognostic scoring systems, but just wanted to bring this up that possibly in the future, this could be one enhancement of prognostic scoring systems. And this recent study in Hemisphere investigated cytokine profiles in more than 400 MPN patient samples. And interestingly, they found an ET-specific inflammatory cytokine signature that consists of eotaxin, Rho alpha, and EGF. Also, GRO alpha levels were predictive of MF progression in ET patients. This suggests that possibly inflammatory cytokine profile could be useful in possibly helping to diagnose the subtype of myeloproliferative neoplasm, but likely more importantly, could envision that monitoring of cytokines could possibly be used as a way to predict progression from ET or possibly PV into myelofibrosis as potentially a harbinger of transformation. And then lastly, inflammation as a therapeutic target in myeloproliferative neoplasms. JAK inhibitors have been the mainstay of treatment for patients with myelofibrosis for many years. We've had ruxolitinib or Jakafi since 2011, and more recently in Rebic or fedratinib in our armamentarium for treatment of myelofibrosis patients. While the activating mutation in myeloproliferative neoplasms does involve constitutive activation of JAK-STAT signaling, it is very likely that one of the main mechanisms of action of these drugs is to reduce inflammation. And it's fascinating that the other diseases in which JAK inhibitors are approved are in autoimmune diseases. So there are a number of FDA-approved JAK inhibitors for autoimmune diseases. This is just further highlighting the similarities between myeloproliferative neoplasms and other inflammatory conditions. JAK inhibitors, such as ruxolitinib, reduce inflammatory cytokines on the left, as demonstrated in the COMFORT studies. But interestingly, a recent study by the OLAB demonstrated that Jakafi or ruxolitinib may not return cytokine levels to normal, reduces them, but not necessarily to a normal level. This brings up the question of, are JAK inhibitors enough in terms of normalizing cytokine levels, or would patients benefit from some additional cytokine reduction beyond JAK inhibition? So possible other potential approaches to reduce inflammation in myeloproliferative neoplasm, there are a number of additional pharmacologic agents that could be used on their own or in addition to JAK inhibitors to further reduce inflammatory cytokines. However, it's also important to think about possible other non-pharmacologic low risk approaches to further reducing inflammation. And things like lifestyle modifications, such as with weight loss or exercise or mindfulness, are being investigated in myeloproliferative neoplasm. We have a small study investigating the role of a diet intervention, in particular a Mediterranean diet intervention, which to lower inflammatory cytokines and reduce symptoms in MPN. And also the microbiome in myeloproliferative neoplasms is just beginning to be investigated. And this represents a possible therapeutic target to reduce inflammation in myeloproliferative neoplasms. These non-pharmacologic approaches could possibly be used as an adjunct to pharmacologic therapies in patients with severe inflammation, such as those with myelofibrosis, or possibly could be incorporated at very early stages of myeloproliferative neoplasm, such as an early stage PV or ET, to reduce inflammation, to possibly blunt progression. And one could even go further, that these lifestyle modifications may be also very useful in patients with pre-malignant conditions, such as clonal hematopoiesis of indeterminate potential. So just to sum up, I'd like to acknowledge my lab. Betty Lai did most of the mouse and the human studies with the anti-IL-10. Other people in my lab who have been instrumental in this work, Bree, Gaja, Laura, and Tiffany. So thank you very much for listening.
Hi there, I'm Dr. Ronald Hoffman from the Mount Sinai School of Medicine in New York. It's a pleasure to give this talk, which is entitled, "What are the molecular mechanisms driving the switch from the MPNs to leukemia?" So just for some background information, approximately 1%, 4%, and 20% of ET and PV and PMF patients respectively progress over a 10-year period from the time of diagnosis to blast phase, termed MPN blast phase. MPN patients with blast phase have a particularly dismal prognosis with currently available therapies, with a median overall survival of 5.8 months. We have learned over the years from a variety of work that the driver mutation in part determines the overall survival of patients with myelofibrosis. And I just want to go over this information for you to put in the effect of the influence of the blast phase on the influence of the driver mutation on the blast phase. You can see that JAK2 mutations are the most common, and they have a median overall survival of 9.2 years. Those patients that have calreticulin mutations have a more favorable prognosis. They include almost 23% of patients. MPL mutated patients have a similar survival of those patients with the JAK2 mutation, while those patients that lack a driver mutation, the so-called triple negative, only include 8.3%, but have a much poorer overall survival of 3.2 years. This is data that I've taken from a paper by McNamara from Toronto, which is 122 patients with MPN blast phase, and shows the number of patients stratified by the number of cytogenetic abnormalities. And I think there's a lot to learn about the molecular mechanisms underlying MPN blast phase. As you can see, 56% of these patients had a JAK2 mutation, 13% had a CALR mutation, 6% of the patients had a MPL mutation, and you can see that 26% of these patients in their original MPN were triple negative, therefore showing the very high risk of those patients who have triple negative disease to develop MPN blast phase. There are on the vertical axis the number of mutations that are present beyond the driver mutations. You can see 30% of the patients have ASXL1 mutations, 25% have TET2 mutations, 22% of the patients have SRSF2 mutations, 20% RUNX1 mutations, and 17% have P53 mutations, as well as 26% of patients have IDH1 and IDH2 mutations. Remarkably, unlike primary AML, only 3% of the patients have mutations in FLAT3 or nucleophosphate. Those patients who are triple negative at blast phase, 34% of them have ASXL1 mutations, 28% of those patients have SRSF2 mutations, and 25% of them have P53 mutations. Now you can see that the majority of these patients on the bottom panel have a large number of cytogenetic and abnormalities, and as well as the molecular mutations. In those patients who only have one mutation, 8% of them have JAK2, 5% of them have P53, and 3% of them have CALR. 3 of them have CALR. Nearly half of the P53 mutations occurred alone or with other abnormalities. It's very important to realize that the majority of mutations are involved either in JAK-STAT signaling or RAS signaling, which involves the genes BRAF, CBL, KRAS, NRAS, and RIT1. And signaling, RAS signaling mutations are associated with a short survival, 1.7 months versus 8.0 months. So one of the common themes of this talk is going to be that P53 mutations and mutations involving the RAS pathway are important in the biogenesis of MPN blast phase. This is again from the McNamara paper showing the influence of these various parameters on survival. And you can see in the panel on the left that essentially the driver mutation really doesn't influence the survival of these particular disorders. Panel on upper right, you can see cytogenetic abnormalities. You can see those patients that have greater than 3 cytogenetic abnormalities have a far inferior survival. And also you can see in the panel on the left and the bottom, you can see that those patients that have a P53 mutation do particularly well with, particularly poorly, I should say, with modern day therapy. In addition, those patients that have greater than 4 mutations, which is the majority of the patients, also have an inferior survival. Well, why is P53 so heavily involved in the progression of these disorders to MPN blast phase? This is a paper that was published from our group in 2018. It's been shown that JAK2V617F is associated with upregulation of MDM2, which is a negative regulator of P53. In addition, there's a high frequency of patients who have abnormalities in chromosome 1q, which leads to increased MDM4, a protein that also interacts with MDM2 to lead to P53, decreased P53 transcription and increased P53 degradation. Furthermore, there are cytogenetic abnormalities that lead 17p that lead to deletion of P53. And also there are mutations in P53 that I discussed with you. And each of these abnormalities, at least that our hypothesis is, occurs over time in these chronic myeloproliferative neoplasms that leads to eventually loss of P53 mutation, resulting in MPN accelerated phase or blast phase. We've attempted to further assess this problem using an in vivo NSG mouse model, which is outlined here in a cartoon. You can see that we take blast phase cells from patients who are in the blast phase. We deplete them of CD3 cells, and then we transplant them into MPN, into NSG mice. And after 1 to 7 months, we essentially analyzed the morphology, the phenotype, and the cytogenetic and mutational burden of the leukemic blast cells. And then we do serial transplanting experiments. And all of this work has really been done by Zhao Li Wang in my lab, and this work is unpublished. So these are the patients that we've used. There are the 46 patients with MPN accelerated phase or blast phase that were enrolled in our consortium's 109 trial. And this is the data from the first 18 patients of the specimens that are taken prior to initiation of therapy. And you can see that all of these patients were JAK2 V617F positive in their initial myeloproliferative neoplasm. You can see that 13 of these patients had MPN blast phase or accelerated phase where they retained the JAK2 mutation, while 5 of them in the MPN blast phase lost the JAK2 mutation. 3 of them, I should say, lost the JAK2 mutation, and 5 of the patients had chronic phase disease where they didn't have the JAK2 mutation. 13 patients were cytogenetically normal. These were the cytogenetic abnormalities. And each of 16 of the 18 patients had at least 2 myeloid malignancy poor risk mutations. How can these 3 patients that started off with JAK2 V617F positive disease develop blast phase in which they lack the driver mutation? This hypothesis was developed by Bejar in 2010 in a paper in Blood. One hypothesis is that there's a pre-JAK2 mutation that occurs prior to the acquisition of JAK2 that leads to a founder clone. In that founder clone where the JAK2 mutation is acquired, that leads to the MPN. And then in another set of cells with that founder clone, the other mutations develop that lead to MPN blast phase. The alternative hypothesis is that there are coexisting populations of normal stem cells, one of which acquires the JAK2 mutation, leading to MPN blast phase. And then there's this reservoir of normal cells that are influenced by the MPN cells and the dysfunctional microenvironment, leading to the acquisition of mutations, leading eventually to this clone predominating, leading to MPN blast phase. So here's the data that we've been able to generate, essentially analyzing these cells in NSG mice. And you can see 7 out of the 18 patients developed essentially MPN blast phase in vivo in these NSG mice, while group 2 did not develop this same kind of disease in the mice. You can see the difference in human cell chimerism, and you can also see that MPN blast phase developed in 1 to 4 months. And the average survival of those animals that developed MPN blast phase was much shorter. This is a complicated slide, but it's an important slide, essentially showing you the molecular features of the primary cells, the leukemic cells in xenograft 1, then in the serial transplant xenograft 2 and 3. Just to sort of use one example here, you can see that each of the specimens, each of the primary cells and also the xenografts in this particular situation was JAK2 V617F positive, but you can see subsequently during further evolution of the disease, you can see in the serial xenografts, there was an appearance of a P53 mutation, suggesting that there are clones that are present that are not detected in the original primary cells, but present. Here's a more interesting patient, again, a patient who had a downregulation of JAK2 in the primary cells, but in the xenografts have upregulation of P53. again pointing out the importance of this particular patient. Here's another patient whose chronic myeloproliferative disorder was JAK2 V617F, but you can see in the primary cells and also in the xenografts, JAK2 was not positive, was not present, but you can see again that KRAS mutation, this common theme that both P53 and KRAS are important in the biogenesis of MPN blast phase. Just to show you the biology of these different diseases, here you can see cells in the mouse bone marrow. You can see as we do increasing serial transplantations, the leukemic cells become more and more proliferative, leading to higher degrees of chimerism, higher degree of CD33 cells. And interestingly, you can see that there's suppression of murine platelet counts and white blood cell counts, implying at least that perhaps these leukemic cells either crowd out or have some sort of molecular or humoral mechanism that downregulates normal hematopoiesis in the mouse. And most impressively, you can see that the survival of these mice, primary, secondary, tertiary, and quaternary, as you do the serial transplants, essentially are diminished, suggesting at least that in the NSG mouse, we're selecting more virulent leukemic clones. So here's a situation where the MPN clone arises directly from the JAK2 V617F positive MPN, and this occurred in 57% of the patients. You can see that the primary leukemic cells and the primary MPN were both JAK2 V617F positive, as were the leukemic cells in the primary xenograft. And you can see that there's an increased selection of a clone that has a P53 mutation in the xenograft. Here's the three instances where the chronic MPN was JAK2 V617F positive, but the blast phase was JAK2 wild type. You can see that in this situation, this was associated with the acquisition of a KRAS mutation in the MPN blast cells. And you can see the additional poor risk mutations such as ASXL1 in the other two instances. Again, here is another patient, which I think is extremely interesting, again, implicating P53 as a pathologic pathway by which you can develop MPN blast phase. You can see that in the chronic MPN, this patient had a JAK2 V617F, while in the MPN blast phase, it was JAK2 wild type. And this patient, as you can look at the blast cells, you can see that this patient had acquisition of 1Q, which leads to upregulation of MDM4, and had deletion of 17P in 80% of the cells, essentially showing you that this is associated with loss of P53. The other important message here is that not only are the mature myeloid cells involved, but also the T cells have this 17P abnormality, suggesting that this disorder arises at the level of the pluripotent hematopoietic stem cell. These P53 mutations are associated with a proliferative advantage of MPN blast stem cells. And here you can see in the primary cells, the variant allele frequency, and you can see that these variant allele frequencies increase for the P53 mutations in the primary xenograft, therefore providing a proliferative advantage. And similarly, for those individuals that required KRAS mutations, you can see in the secondary and primary xenografts that there's also a proliferative mutation. And this is in contrast to those individuals who have coexisting TET2 mutations. You can see that the acquisition of TET mutations or the presence of TET2 mutations does not lead to a greater proliferative advantage, suggesting that RAS mutations and also P53 mutations are important players in the development of MPN blast phase. So we all realize, and there'll be many talks about this in this meeting, that JAK2 inhibitors are now the standard of care for patients with myelofibrosis and also polycythemia vera. And one of the big questions that's been ricocheting around the community is does Jakafi therapy or ruxolitinib therapy prevent MF disease progression? And I think this was best addressed in a paper that was published this year from Myelonis, working with Frederick Dahm in Berlin, that was published in Nature Communications. And let's focus here on the three patients that went on during their period of time of observation to develop leukemia. You can see that those are patients 2, 4, and 18. So try and keep those numbers in mind. So the whole idea here is that these investigators did whole exon sequencing, and then at the time of diagnosis or early on in the course of their disease, and then did whole exon sequencing at the time of development of MPN blast phase. There's a lot of overlap between the data that we showed in our NSG mouse model. Two things that strike you here is here you can see 4, 18, and 2. You can see that the variant numbers of mutations was much higher in 2 of the 3 patients that went on to develop acute leukemia. They're very consistent with the data from Toronto. And you can see here's the representation of these high-risk mutations that we discussed, again, based upon the data that was presented previously. What happens during when you examine these patients prior to JAK2 therapy and following JAK2 therapy? Here's the number of mutations per patient, and you can see here's the baseline whole exome sequencing, and this is the last time point. You can see there's an increased incidence of mutations. Between the primary specimen and the MPN blast phase, there are 162 common mutations, 39 mutations are lost, but 80 mutations are gained. And when you look at the blue, you can see that the KRAS family members, or the RAS family members, are heavily represented. Again, NRAS, CBL, HRAS, BRAF, and RIT1. Again, emphasizing the lesson that we learned from the NSG mouse, that RAS mutations, RTK pathway mutations, play a big role in the development of MPN blast phase. So in summary, our data collectively shows that MPN blast phase is a stem cell disease. It's closely associated with genetic abnormalities in P53 and RAS. MPN blast phase can originate in clones which possess or lack the MPN driver mutation, and occurs much more frequently in patients who lack a driver mutation. JAK2 inhibitor therapy does not appear to create a clear evolutionary bottleneck in MF patients and does not prevent evolution to MPN blast phase. In patients receiving this class of drugs, a more complex clonal architecture as well as unrelated clones appear over time. And that was shown both in our NSG mouse model and also in the work from Berlin. And unfortunately, present therapy for MPN blast phase is minimally effective and at best serves as a bridge to allogeneic hematopoietic stem cell transplantation. So I'd like to thank you for your attention, and then we're going to move on to further discussions. Thank you. And our last speaker is Nicole Kucine, a fellow New Yorker. Nicole is in the pediatrics department at Weill Cornell Medical School here in New York. And she's going to give us her unique perspective on myeloproliferative neoplasms in young patients, a really fascinating area of research that I think we should spend increasing amounts of time.
Thank you so much to the organizers for asking me to speak to you today. Good morning, everyone, and I'm really excited to talk to you about MPNs in young patients. So I have no financial disclosures, but I will be discussing off-label use of medication in children. So in the next 15 minutes, we'll review some of the current pediatric and young adult MPN literature. We'll talk a little bit about our pediatric MPN research program at Cornell, and we'll think about some of the challenges and unanswered questions we face for young MPN patients. So, newsflash, children do get MPNs, but they're rare. It's been estimated that for every 100 adults with an MPN, there are maybe 1 to 2 children diagnosed. So let's take a look at some of the literature that's out there. Last year in 2019, a group in Europe put together a systematic review on pediatric MPNs. I give them a lot of credit for doing this. It must have been extremely challenging given the limited literature that's out there. But they were able to identify 46 papers of cohorts and case series that included 396 children with ET and 75 children with PV. And then in the past decade, a number of groups have been sharing their experience regarding young adult patients with MPNs, so patients under the age of 40. So if we look at the different studies, we can see that the systematic review really did capture a pediatric cohort. The median age is much lower than what we see in the young adult papers. And the thing that I think was most interesting was the rate of driver mutations. And the pediatric cohort really had significantly higher rates of triple negative disease. You can see, for example, the JAK2VF mutations in both the pediatric and young adult cohorts are quite different, especially for the PV patients, with at least 70% of the pediatric PV patients being negative for a JAK2 mutation. The authors appropriately questioned this finding and wondered about the actual diagnoses of these patients. The authors did say that they used WHO criteria. However, it's not clear that they truly met the diagnostic criteria for PV. But I just thought that was really interesting. And also looking at the CALR mutation in the ET patients, those are much lower as well. We can see that both at diagnosis and after diagnosis, pediatric patients do get thromboses. They're largely venous, somewhat lower rates than the young adults, but they do happen. It's not insignificant. And I think the most reassuring thing we can see is that in the pediatric population, both fibrotic and leukemic transformation are quite rare. And these rates were fairly low for young adult patients as well. And the majority of the studies found that the overall survival of young adult patients was much better than the older adults. But I think this is information that brings a lot of reassurance to families when we counsel them. So at Cornell, we have an ongoing prospective pediatric MPN study. We have 36 patients enrolled at Cornell, and we're enrolling some additional patients with colleagues at UCSF. The median age of diagnosis in our cohort is 10 years old with a range of 2 to 20. So again, it's truly a pediatric cohort. When we look at the mutational spectrum of our patients, you can see that 39% of our patients have JAK2VF, 5% of our patients have JAK2 exon 12, 14% of our patients have a CALR mutation, 3% of our patients have a MPL mutation, and then 39% of our patients are triple negative. So this is more than what's seen in the adult patients, but it's still less than what was reported in the systematic review. Making the correct MPN diagnosis in kids can be a little more challenging. So 21 of our patients have ET, 5 patients have PV, 1 patient was diagnosed with pre-myelofibrosis, 1 patient has fulminant myelofibrosis, 2 patients were diagnosed with post-ET myelofibrosis, and then 6 patients were diagnosed with MPN unclassified. So these are patients who we think have polycythemia vera. Both ourselves and other experts at other centers have agreed on this. They have very low EPO levels, they have JAK2 mutations, they have very pleomorphic megakaryocytes, as you can see in these examples, but they don't necessarily meet the WHO criteria because of their hemoglobin and hematocrit cutoffs. So our group actually proposed that having pediatric-specific criteria based on age and gender for some of those red cell values might be more useful for children. Again, the WHO criteria were really designed for adults. So those cutoffs for H&H are really for adults. So making the correct diagnosis in children might mean rethinking the way we view red cell cutoffs. So when we look at the MPN-associated complications in our patients, 2 patients had bleeding events. 1 presented with very severe epistaxis that required transfusion. 1 patient had gastritis and GI bleeding that was actually thought to be due to overuse of NSAIDs and not her MPN. And then 5 patients had thrombotic events. Interestingly, they were all female. 4 of them had Budd-Chiari, 3 at the diagnosis or presentation of their MPN, 1 later on. All of those patients were JAK2VF positive. And then 1 patient developed a cerebral venous sinus thrombosis and pulmonary embolism during the course of her illness. She had triple negative ET, and of note, her platelet count was normal at the time of the clot diagnoses. 2 of our patients had pseudotumor cerebri, but there was no evidence of cerebral venous sinus thrombus on imaging. And 1 patient did have a transient ischemic attack, but there was no evidence of stroke on imaging. And with over 130 person years of exposure, we've had no cases of transformation to AML in our cohort, which again, I think is really reassuring for families. So one question that comes up with our young patients is treatment, and what are the appropriate treatment options for kids? I think in pediatrics, often providers will go to hydroxyurea first because it's something we have a lot more experience with in treating sickle cell patients. So it's a drug that we've used. So oftentimes I will see patients who are already on hydroxyurea when I meet them. But there's very little literature on using interferon, especially pegylated forms, in kids with MPNs. So we got together with colleagues from 5 other centers and put together a small cohort of 13 patients who were treated with PEG so that we could provide some more data for the general population. So in our cohort, the mean age was 10.5 at diagnosis with a range of 2 to 18. So again, this is a truly pediatric cohort, and the range of age for starting PEG was 3 to 22 years. It's about 2 to 1 split female over male and pretty evenly distributed between PV and ET. 6 of our patients had JAK2-VF mutation, 2 had exon 12, 1 had calreticulin, and 4 were triple negative. 7 of our patients were treated with hydroxyurea prior to starting interferon. The reasons for starting interferon in this cohort were varied. Some families were concerned about leukemic or fertility effects that could be attributed to hydroxyurea. Some needed better count or symptom control, and some didn't like the side effects of hydroxyurea. If you look at the duration of therapy, the median duration of therapy in this group was 24 months, but you can see that some patients were really on interferon for a number of years and had very long duration of therapy. And the doses ranged from 45 to 153 micrograms of PEG. So 2 of the patients on PEG developed thrombotic events, and 1 patient had a bleeding event, and that was, again, the young lady with gastritis that was due to NSAIDs. So in the end, 5 patients discontinued PEG, the 2 patients who had thrombotic events. 2 of the patients did develop depression and anxiety that required discontinuing medication. They did not have suicidal ideation reported, but they still couldn't stay on the med. And then a 5th patient developed persistent transaminitis in the setting of having had a liver transplant post-Budd-Chiari presenting with his MPN. And when he stopped his PEG, his transaminases returned to normal and stayed that way. 8 of our patients are currently still on PEG. 1 remains on combination therapy with low-dose hydroxyurea and is doing very well. 1 patient was started on ruxolitinib for persistent symptoms, and the other 6 are still on PEG doing quite well. And just to note that serial variant allele frequencies are not really done very often in pediatrics, but 2 of the patients with JAK2 mutation did have multiple tests done and did show decrease in their variant allele frequency of the JAK2-VF. So another thing we wanted to look at is protein expression in our patients and to see how do they look different than other patients. So working with colleagues at Seattle through the Children's Oncology Group, we were able to perform RNA-seq on a cohort of our pediatric MPN patients and compare that to both normal controls and a large cohort of AML patients who had been collected through COG studies. So some interesting things, when we looked at pathway enrichment, we found that of all the pathways, the lupus pathway was actually the most heavily enriched in our MPN samples, which was quite interesting. And we saw a number of inflammatory and immune and proliferative pathways that were upregulated. When we looked at individual genes, we could see that PF4 and PF4 variant 1 were heavily upregulated in our MPN patients. PF4 is a platelet-derived chemokine, CXCL4. There's literature showing that endogenous anti-PF4 heparin immune complexes form in MPN patients. This is similar to what we see in heparin-induced thrombocytopenia, which is a very prothrombotic disorder. So thinking about potential mechanisms of thrombosis in our patients. And a paper came out last month showing that increased PF4 expression was linked to inflammation and fibrotic progression in myelofibrosis patients. So again, thinking of disease mechanisms in these young kids. And when we looked at our JAK2-VF patients, we actually saw upregulation of complement genes, including CFB and C2, which was really interesting to think about. There was a great poster at ASH showing that PF4 and heparin immune complexes are shown to activate complement. So again, thinking about the interplay of all these inflammatory genes and different mechanisms of inflammation and thrombosis in our young patients. So some of the unique challenges we face in younger patients include lack of experience in pediatric providers. There's a lot of pediatric hemonc docs who will make it through their whole career and will never see an MPN patient or will maybe see 1. So given that the literature is so limited, this can be really frustrating for both providers and families, the fact that there's just not a lot of experience out there. You know, the struggle of having an extremely rare disease and being sort of the only one in your class, in your town that you know of with an MPN can be extremely isolating and challenging for our young patients. And I think one of the best things we've done for some of them is connect them to each other and connect their parents together for communication and community. And the MPN Advocacy and Education International Group has been really essential, I think, in bringing some of these families together, which is just so important. Health insurance is a big issue for young patients. You know, young people fall off their parents' insurance coverage at the age of 26. Child Health Plus coverage generally ends at the age of 19. So thinking about how to get insurance coverage for someone with a chronic disease, if they may not be able to get it through school or work, can be extremely stressful and challenging. And then fertility concerns for our young patients. This may not be something that comes up in conversation with your 60 and 70-year-old patients, but it's really important for 20 and 30-something-year-old patients who are thinking about starting families. So thinking about ways to support fertility issues and safe pregnancies with MPNs. There's a lot of unanswered questions that we face in young patients. I think one of the ones that I struggle with the most is when is the right time to start cytoreductive treatment? You know, there's no clear guideline on when to do that in kids. And, you know, through conversation with colleagues, we've talked about, is it based on platelet counts? Is it the presence of acquired VW where it may limit sports participation or quality of life? Is waiting until a thrombotic or bleeding event occurs the best time to start? Is, you know, basing it on symptoms the right thing to do? I don't think we know. And I meet kids from all over who are started at various times, and we just don't know when is the right time to introduce cytoreduction into a patient's course. And in line with that, what treatments are appropriate for young patients, we just don't know. In the systematic review that was put out last year, it showed that twice as many patients were treated with hydroxyurea as compared to interferon, but we have no evidence or data that says that that's the right thing to do for young patients. And adult guidelines are now recommending considering interferon upfront for younger adult patients. So should we be using interferon more in young patients? Are there other drugs coming down the pipeline that might be more appropriate for kids? We just don't know the answer yet. Something that bothers me as a pediatrician is thinking about iron deficiency in some of our young PV patients. We know that iron is necessary for normal growth and development. And when we face a healthy child who happens to have iron deficiency or iron deficiency anemia, we fix that. We don't leave that iron deficiency untreated. We want to replete those iron stores. But when dealing with a young PV patient who might be iron deficient purely because of their disease or because of the phlebotomy treatment they're on, it's not so clear cut. And we really don't know what are the long-term effects of those lengthy periods of iron deficiency in these young kids. And then the question of triple negative disease. Again, it's more common in young patients. We don't know what the drivers are in some of those patients, and we're trying to figure that out. Thinking about germline versus somatic mutations, thinking about what other pathways might be involved. So these are questions that keep me up at night and keep me in the research world, and things that I think we really need to figure out for our younger patients. So we still have a lot to learn, but we know that children do get MPNs. We know they have lower rates of transformation. We know they have higher rates of triple negative disease. And we've seen that they can have varied symptom profiles and they can have thrombotic complications. So these really aren't completely benign diseases in young patients. But research is ongoing, and I think we're trying to get to the bottom of a lot of these unknown areas and questions. So thank you to a lot of people, especially Ross Levine, who's been a research mentor of mine for a very long time, and a number of other colleagues. Thank you to all the patients and families who are really so interested in participating in the research. Thank you to MPN Advocacy and Education International for their support of my work and for connecting patients to me and to each other. And thank you to the NIH for giving me money to do this research, and to the Children's Oncology Group for teaming up with me for the RNA-seq. And I'm happy to take any questions.
Hello, everyone. My name is Stephen O. I'm from Washington University School of Medicine in St. Louis. Welcome to our live panel discussion. You all just heard some really outstanding talks by some of my colleagues and experts in the field. I'd like to welcome everyone to this panel discussion. And I know that some of you have put in questions for our speakers. We'll try to address those as well as have a broader discussion about some of the themes that were raised in these talks. A few of the questions are very clinically related, and we're going to defer some of those to the later session, which is focused on more so clinical aspects, including JAK inhibitors and things like that. But I'm going to start just by asking a couple questions of Nicole with the talk that we just heard. And apologies in advance if I restate anything from your talk, because I was trying to get ready for this live session. But first, just a real basic technical question. So Nicole, I saw you did some gene expression profiling. Did you do that on whole blood, PBMCs? What kind of cells did you do that on?
So we did PBMCs for the majority of the patients, and we did have some bone marrow mononuclear cells from the AML cohort through COG. Got it.
And so you saw, it sounds like evidence of increased inflammation in your young MPN patients. That, of course, seems to be a theme that many groups have now published on in the MPN field. I wonder if, well, one, have you done any plasma cytokine analysis?
So we're in the process of doing that. The machine in the lab is currently down. So as soon as it's back up, hopefully in the next week or two, we will do that. We have our MPN patients, then we have a cohort of normal controls to compare them to.
Got it. So, one of the questions that I've been wrestling with, and I can open this up to the group, including Angela's, again, it seems that inflammation is a theme here, whether we're talking about CHIP all the way to different types of MPNs. But is it a driver, and is it a consequence of the MPN, and does it specifically specify the type of MPN? I think it was in Angela's talk, you referred to a recent study focusing on ET and a specific cytokine signature. But I'm wondering, for instance, in your young MPN patients, if you'll find that cytokines are increased across the board in a similar fashion to older MPN patients. One of the questions that I've been wrestling with is how they quite distinct. Again, it seems that inflammation is a theme here. And we found that, if anything, they were more similar than different between the young and the old, both abnormal, but worse or more exacerbated in the older patients. So that was a long comment and question, but the bigger point is, is it going to be the same or different in these younger patients, do you think?
It's a good question. I don't know. I think inherently we don't know enough yet about pediatric disease, but I think there are some kids who really do have truly a disease that looks like something you would see in an older adult, especially the JAK2 mutated kids. So I think it's possible that we'll see some similarities. And I know Rajit Rampal is looking at cytokines and inflammation in sort of his young adult cohort of patients. So it'll be interesting to compare them to the kids and compare to what's in the literature for older adults. I don't know, Angela, what your thoughts are on that.
Yeah, I was just going to ask you, anecdotally, did the Sorry, I'm wondering with the kids anecdotally who have do you notice that they have had some sort of inflammatory crisis, like they were hospitalized with a serious infection, anecdotally, do they tend to have sort of inflammatory storms that occurred at some point in their life?
I would say a smaller percentage of the kids I've met have sort of presented in the setting of illness, or something was going on because they were sick when they presented. And then there's certainly some kids who presented with Budd-Chiari syndrome, so they were quite ill at that time, and that was how their MPN got diagnosed. But a lot of kids get picked up on sort of incidental blood work that's done by their pediatrician for school or for routine screening for anemia and things. So a lot of times the kids seem perfectly healthy and they get incidentally diagnosed with an MPN.
So I think that's an important question. Is there something predisposing these young patients to develop an MPN? Are they randomly acquiring a JAK2 mutation, which would be less likely in a young person, but could happen? Do they have some baseline inflammation? Have you done any kind of germline analysis to look for predisposing alleles and things like that?
So we're working on that now, and there's been some studies. There were a couple of case reports of very young children with a JAK2 mutated MPN who somebody very smartly went back to their newborn screen blood card when they were born and found JAK2 VF on that sample. So thinking about, was that, a germline sample? Was that an in utero acquired mutation? I think we don't know. And thinking about, I know this is something that Angela thinks about a lot, thinking about, is there any kind of familial predisposition? Are there family members with a positive history for an MPN? That's things we try to ask a lot of detailed questions about to try to get to the bottom of. And most of the kids I've met do not have a positive family history. That seems much rarer.
Got it. And you may have mentioned this, but have you just looked for other somatic mutations besides the three main driver mutations in your analysis thus far?
So we're just finishing up sequencing our cohort, and we're using the HemePact panel over at Sloan Kettering, which is about 600 genes. So we're starting with that analysis to see if it gives us any more insights into drivers, especially in the kids who are triple negative. I think they're probably very interesting.
Yeah, and you mentioned, I think it was 70% of your young PV patients are actually JAK2 negative. Or at least
so
JAK2.
that was in the systematic review that got published. So in our cohort, it's a much higher number that are JAK2 positive. The authors of the systematic review chose papers that said they used WHO criteria, but I have to wonder if those individual papers really truly identified true PV patients, and they questioned that. They said 73% of that PV cohort being negative for JAK2 is unexpected, I think. So I don't really know if that was a true cohort of PV patients. If it was, that's a very high percentage for JAK2 negative. It's not what we've seen in our cohort at Cornell.
Yeah, I agree that, it's far more likely that there's, it's a secondary or congenital form of erythrocytosis other than your, typical, somatically acquired JAK2 mutation driven PV.
Right. All the PV patients we have enrolled on our study are JAK2 positive, either for VF or exon 12.
Got it. And then you mentioned, again, I missed parts of this, but experience with interferon in your young patients. And I guess the broader question, which I think you had in your concluding slide, of when or how or whether to use cytoreductive therapy at all in these young patients. So, because, as an adult MPN clinician, your typical young patient, unless they presented with splanchnic vein thrombosis or something like that, we would consider them low risk. We wouldn't necessarily initiate cytoreductive therapy at all.
Yeah, it's a really interesting question, and there are certainly times where I meet a kid who's already on cytoreduction and I don't necessarily think they need it. Like you said, splanchnic vein thrombosis, 100%, those kids are going to get started on something. And then it's one of those things where there's not a magic number, and I've met patients who presented with platelet counts of 4 million, and I don't know a lot of pediatric clinicians who would be comfortable sitting with that number, so they get treated. And I don't know that that's necessarily right or wrong. And there are certainly kids who do have bad symptoms and they need something done, and they don't necessarily respond to aspirin, or they have acquired VW and they can't take aspirin. So thinking about those kids. So I do think there are times where it's a little clearer, and then there's a lot of times where we don't know. And I think counseling the families and sort of presenting all the different options is the best thing we can do as clinicians.
Absolutely. Okay, so let me open this question up to, I think everyone might have an opinion or comment on this. So some of you touched on, of course, inflammation, but also the role of JAK inhibitors, both in general. Of course, we use them quite frequently to treat MPN patients these days. But the question of, one, how do these act as anti-inflammatories? Number two, and Rafael, in the setting of CHIP, is this something that actually could have important benefits in that regard, both in terms of thrombotic events, cardiovascular complications, but also I think there's a question that connects to Ron's topic of, does this impact disease progression? And my opinion is that, and part of our work relates to this, that although these drugs do reduce inflammation to some extent, they're not, in any way normalizing the inflammation. And clinically, it does not seem that we have any strong evidence that they modify the natural course of the disease in terms of clonal evolution and things like that. So, if this again ranges from, if we're thinking about CHIP, like the concept of, would you want to put someone on a low dose JAK inhibitor for an extended period of time? Is that actually going to be beneficial? Maybe it might be for thrombotic events, would it be in any way alter the likelihood of CHIP progressing to MPN or MPN to a more advanced stage? Let me kind of throw that out there.
I guess I can start and talk about CHIP in particular. I think that this concept of inflammation in CHIP is obviously not unique to the myeloproliferative neoplasms. It extends to all the chronic myeloid disorders, MDS included. And I'm not sure that JAK inhibition is really going to address the primary kind of inflammation that we see in these patients. I think it's really driven more by the NLRP3 inflammasome. And there have been studies that ask this chicken and egg question: is it that the mutations engender this inflammatory environment, or is it that the inflammatory environment selects for these mutations? And I think the answer is actually both. I think there is this positive feedback loop that occurs. And if we can break it, it might certainly make an impact on disease, but it's not entirely JAK-STAT mediated. So I'm not sure that low-dose ruxolitinib is going to necessarily have an impact on thrombotic events, even if it does alter anything that has to do with clonal evolution. And it's interesting that even in patients who have PV, if we phlebotomize them, we see thrombotic risk go down. So it isn't just modulating the inflammation that associates with that. So I have a feeling that these drugs are not going to have a place in CHIP, but there may be others that do.
Yeah, I mean, I would just add that obviously we don't think the JAK2 inhibitors, right, are strongly clonally selective for JAK2 mutated cells. And so therefore, if the goal is to try to target the JAK2 mutant clone, I think, well, obviously we need to do trials, right? I don't think we can empirically put people on JAK2 inhibitors that are drugs that have substantial side effects associated with them if we don't have any data to support doing that. And obviously, I think one limitation would be whether they would actually be able to target and be clonally selected for the mutated cells, which at least in myelofibrosis, they don't appear to be strongly selective. They seem to be a little bit better in PV based on published data. But I think we obviously, this is an area we need clinical trials in before we start sort of empirically doing these type of things.
I'd like to comment on this. This is Ron. I think the clinical trials are.
You're muted, Ron.
I'd like to comment on this. The clinical trials that are going to be required are going to be extremely difficult to do. They're going to require thousands of patients with long-term follow-up, and we as a community are not good at doing those kind of cooperative trials, but before embarking on empiric use of these types of agents that are not innocuous, those kinds of trials really are going to have to be rigorously performed with careful longitudinal studies. And I think the data that was presented from one of the papers showing that the JAK2 mutation preceded the myeloproliferative neoplasm by many years, and also the work that Nicole presented showing that, to my shock at least, the patients with pediatric MPNs had a very high incidence of thrombosis, that such trials really have to be carefully done before embarking on such empiric therapy. I know cardiologists at our institution are talking about this very actively, and it really scares me.
So Angela, let me ask you, if whatever mechanism it was, if we had a more potent anti-inflammatory agent to treat MPN patients with, would you predict that actually could have a clonal impact, or is the notion that more aggressively targeting inflammation, is that really fruitful, or do we need to think about other ways to leverage these pathways?
I mean, I think that targeting inflammation is extremely important in MPN, but may need to be part of the armamentarium. In particular, possibly at the very early stages of MPN, maybe even going back to the CHIP phase, might be the point where targeting inflammation may be the most impactful. Whereas I feel that at later stages, such as in myelofibrosis stage, where inflammation is the greatest, I think that probably just targeting inflammation may not cut it. You probably need additional agents that will specifically target the mutant clone, but wanted to highlight that maybe at the very early stages in catching people in the CHIP phase, or sort of that when they have a JAK2 clone but are not necessarily displaying any overt clinical signs of an MPN, may be the ideal phase to go in and target inflammation to prevent then the subsequent development of an actual clinical MPN. So basically when I'm saying early stages, targeting inflammation may cut it, but in the later stages, you may need something more.
And that's something also that will be pretty difficult to carry out as a clinical trial, right? Because you're going to have to follow these patients for a long, long time, right? And maybe in the context of a basket CHIP study where JAK2 CHIP patients are included, that might be a little more feasible, but it's still going to be pretty tough, right, to answer that question. Let me turn to some of the questions that have been put in by our colleagues. So Belinda Guo asks, does inflammation contribute differently to disease establishment and progression in triple negative MPN compared to JAK2 MPN or CALR positive MPN? And there's a related question essentially asking if you have a young person with high platelets and no mutations, in other words, negative by some sort of NGS panel, would you conclude that this might be reactive, or is this a true triple negative, or as I like to call it in some of these patients, NGS negative MPN? Obviously, we know we should rely on WHO criteria. We should get a bone marrow biopsy, look for the defining morphology in the bone marrow, but these are challenging cases, right? So there's the clinical question, and then the sort of basic science question of, do we know how inflammation might contribute to these cases?
I don't know, Angela, I feel like the inflammation question was maybe for you, and maybe the young patient question was for me. I can answer from a clinical perspective. So triple negative ET is more common in young patients than in adults. I certainly think that if you have a patient who presents and is, as Stephen said, NGS negative, I think it certainly behooves you to really make sure you've ruled out an underlying disorder. We do a lot of screening kids for autoimmune things, for infections. We follow them. I don't necessarily give someone a diagnosis of triple negative ET the first time I meet them, but I think, we've had a handful of patients who they do have a bone marrow where their megas do look like they have ET. They aren't sick. It goes on for a period of years. I'm sort of hard pressed to call something reactive thrombocytosis, which is common in kids, but if there's nothing that they're clearly reacting to. So it's one thing if you have a sick kid, very easy to say that, and we see that all the time. But if you truly have a healthy, normally developed, normal growing young person who has, abnormal megakaryocyte morphology and has high platelets that we really can't explain over a period of time, I think I'm sort of hard pressed not to call them triple negative ET if they really meet the WHO criteria without a mutation. But I don't necessarily label someone as that right away. And I think sort of really making sure you've evaluated that patient clinically to make sure there's not an underlying, inflammatory bowel disease, lupus, something that's not quite declared itself yet, but is on the horizon. I think making sure that they get a good evaluation and that they're followed over time is important so that you've sort of ruled out the other things.
Yeah, I agree, and I think that I can sort of think of two different patients in my patient cohort who both are young women with elevated platelet counts, and I think that NGS who are both triple negative, and I think that NGS sequencing is really helpful with an extended panel, whereas one has a DNMT3A mutation, and then with subsequent sequencing now has a new clone. So that woman must have some sort of evidence of some sort of clonal process going on. She doesn't have any of our classic MPN driver mutations, but there's clearly clonal evolution occurring in her hematopoiesis, whereas the other woman has absolutely no somatic mutations on NGS sequencing. And I tend to think that in her situation, that's more of a reactive thrombocytosis picture. So I think that probably an extended NGS panel is quite helpful to try to tease out whether there's a scent of a clonal hematopoiesis going on.
Even there, it's tough, right? Because is it really believable that the DNMT3A mutation is causing thrombocytosis? Perhaps, But it could also be a, incidental CHIP clone. I don't know what the other.
Yeah, I mean, I'm not saying that the DNMT3A clone is causing her thrombocytosis, but a 30-year-old woman shouldn't necessarily have a DNMT3A clone and then a year later have a new clone coming up. There's some sort of clonal evolution occurring in her hematopoiesis, and maybe her thrombocytosis is caused by another clone in a mutation that was not included in that 600 gene panel.
So a broader question related to that, I think, it's well established in the literature, and I think you probably have all seen it anecdotally, that some patients, for instance, their JAK2 VAF, it expands over time, right? Just kind of inevitably goes up and up if you measure it serially. Other patients, they establish it at whatever level, say 20%, and it just stays there. It doesn't change over time. So what explains that? Is it treatment? Is it inflammatory insults? Do you guys have any thoughts on that?
I can only speculate. I mean, that same question you can ask about patients with CHIP who have these small clones that persist for years and years and years without expanding. What got them to the level of detection, and then why didn't they go any further? And you can imagine a couple of different scenarios for why that might be the case. I think one of the ones that's appealing is this idea that the mutated cells have the ability to live maybe in a less favorable niche, but that there's a limited number of these. So they expand until they fill those, and then they can go no further without subsequent evolution or other insults that allow them to do so. But I think that that's a great question, because I think if we understood that better, it would afford us some really interesting novel opportunities for intervention.
So I'll tie this to a question for Ron that was raised, asking if P53 VAF has the impact on risk of progression to blast phase MPN. And I'll connect that to an anecdote. I have a patient who was found to have a P53 mutation a couple of years ago. I was not following the patient at the time, but obviously that raised a high level of concern. Now, the patient had been cared for by other doctors, came back to me recently, and lo and behold, 2 years later, still doing okay. So, it doesn't always happen that these bad actors result in imminent transformation. It still could come, but it hasn't thus far. So I don't know if you want to comment on that, Ron.
Yeah, I do want to comment that I think it's very important. I think it's a combination of events, at least in our findings, that those patients, for instance, who solely have a P53 mutation, they have a lower frequency of progression. But those patients that have loss of the other allele, let's say by deletion of 17p and loss of P53, or have 1q, or a mutation on the other chromosome, those patients are at a higher risk of going on to develop MPN blast phase, especially those individuals that have very, very high VAF. So it takes a sort of a synergy of events beyond the single mutation to lead to blast phase.
One other question I have for you, Ron, from the data you showed from your xenotransplants, it looked like I think it was 3 examples of patients who the blast phase was JAK2 negative. By the diagrams, it seems that there was no unified pre-JAK2 mutation that you found, that this looked like in a completely independent clone, at least by the analysis that you did.
That's correct. That's correct.
And one thing I wonder about in some of these cases is that could it be that the treatment, for instance, could have impacted the development of an independent clone? I know there's controversy about long-term hydroxyurea use and leukemiogenicity. I personally don't feel that it's a strong contributor, but do you think there's an impact there in some of those cases?
I think that's something that has to be very carefully examined. Obviously, this has been batted back and forth in the literature with a lot of emotion. I think with cool heads, we really have to take a look at that. Our patient sample size is 46 patients, which is much too small to make that kind of global statement. But I think we as a community really need to take a look at this. I think it's a very important suggestion. Obviously in CLL, there's some suggestion that the administration of particular agents will lead to clonal evolution. I'm not sure that's really established in MPN with some sort of strength.
I mean, and just to add to that, I mean, another consideration, right, is just the presence of having MPN, right, and chronic inflammation in your bone marrow related to that, right, there is some evidence to say that that could be permissive, right? You make the bone marrow environment permissive to the emergence of other independent clones, and even in the absence of any therapy. And I think there is evidence to support that in experimental models, that sort of having a chronically sort of inflamed bone marrow could allow other independent clones and even be more permissive to the emergence of other clones, even in the absence of any therapeutic intervention. So that's sort of the counterpoint to whether these are therapy induced or even related at all.
Good point. Okay, let me mention a question from Ruben for Nicole. How does features of puberty impact MPN symptoms or counts?
That is an excellent question that I can't answer. I don't think we know, but I have seen some kids who, as they go through puberty, it does change their symptoms to some degree. And you also worry about younger kids who have acquired VW, maybe not causing problems, but then the thought of when they get their first period, and it's very common for your young women to have dysfunctional uterine bleeding the first few years of their period anyway, is that going to, increase menorrhagia risk and bleeding and things like that? So it's certainly something I think about, and I, discuss it with families when that is approaching, but I don't think we have any really good evidence yet of what changes that can cause.
Got it. And Linda Rosar would like to know, were the allele burdens in your talk from the peripheral blood?
So they were mostly from peripheral blood in cases where they were from a variety. Some are from bone marrow, some are from peripheral blood. I mean, one thing we have found, we have a research study trying to sort of understand how accurately, peripheral blood variant allele fractions sort of capture what's going on with the bone marrow. And I think what we're starting to find is that when you look even within different myeloid compartments within the bone marrow, so for example, if you look within the megakaryocyte erythroid compartment versus the granulocyte compartment, there is quite a degree of variability in an individual patient in their variant allele fraction. And so when we sequence peripheral blood, we mostly sequence granulocyte DNA and lymphocyte DNA. Whereas in the bone marrow, we sequence, obviously all the nucleated cells. So I don't know that I necessarily sort of pay, massive attention to the variant allele burden in any context, because I think as I said, within, so for example, we have a patient who had, for example, a JAK2 exon 12 mutation who has a single digit variant allele fraction. But if you look within their erythroid compartment, it's essentially all arising from JAK2 mutant erythropoiesis. So I think that in the specific case that I mentioned, I think 2 of them were peripheral blood, 1 was bone marrow, but I sort of take that caveat into consideration in terms of looking at these variant allele fractions and how accurately they actually represent the disease burden within an individual patient, these bulk NGS sequencing variant allele fractions.
Yeah, certainly scientifically, there's some interesting and important questions there with the different cell compartments. Clinically, for instance, in myelofibrosis, if you're going to send it from bone marrow, obviously you're typically dealing with a heme-dilute aspirate, so it kind of gets confusing what your source is in the first place. I tend to, for that reason, just use, I have a low threshold to just use peripheral blood.
Mostly use peripheral blood. If they're doing a bone marrow, then on a diagnostic bone marrow, we typically send it off bone marrow. And I think there's good correlation between bone marrow and peripheral blood. But I guess my point is, if someone has a single digit sort of variant allele fraction, I don't necessarily think of that as sort of having less burden of disease, because I do think, I'm not sure how much these bulk NGS quantitative VAFs, sort of represent what's actually going on within different cellular compartments within the bone marrow, particularly within the megakaryocyte erythroid compartment. And remember, we're not capturing that in peripheral blood generally, because we're really sequencing just nucleated cells, right?
So related to that, I guess, Rafael, there have been, I think, different cutoffs that have been proposed for the VAF to designate someone as having CHIP. Maybe you can elaborate on that for us and how that intersects with diagnosing an MPN. We see, kind of like what Anne was alluding to, JAK2 VAFs can be all over the map in a patient with a modified MPN. So, when you get those low JAK2 VAFs, does that really sort of mean anything to you in distinguishing CHIP versus an MPN?
No, that's a great question. And I think that there are differences. When we think about CHIP and we think about the DTA mutations, DNMT3A, TET2, and ASXL1, I do think that these very small clones probably have less clinical significance. But for the MPNs, as Anne alluded to, a small clone could represent a small proportion of hematopoietic stem cells with tremendous capability to generate progenitor cells and output. So I think that the threshold is likely to be clinically significant at a much lower level for MPN-related mutations that are primarily proliferative. So it was interesting that one of the studies that I mentioned, that where they did very sensitive sequencing techniques, they identified that most of the individuals in the population who had JAK2 clones had it at less than 1%. And these persons actually had an increased thrombotic risk, even at that very low VAF. So it suggested that the clinical significance begins much lower. What the right threshold is, I'm not exactly sure, but it probably is much less than the 2% that we typically associate with the definition of CHIP.
Great. All right. So we have just about 1 more minute left. I'm going to ask if any of you want to ask each other questions. Go ahead, Ron.
I'd like to ask Anne a question. So I came in a little bit late, but I got the tail end of your effect of interferon and CALR in JAK2V617F, which suggested that the JAK2V617F cells were more sensitive, if I understand, and also at a stem cell compartment. If that was true, and I presume it is true laboratory-wise, I know it's true, how would you explain the higher incidence of MPN blast phase in patients that have JAK2V617F mutations? Because you would imagine that essentially that would be a more indolent disease. And I'm not aware of any data that would suggest that interferon essentially, if the data was correlated with the clinical data, prevents evolution to MPN blast phase. So how does that?
So I think, there's 2 points here. One is sort of JAK2 versus CALR mutant disease in the absence of treatment. And then the second point is sort of how does interferon have the potential to modify, disease, right? So I think, and this is sort of linked into Nicole's point earlier of, when should we start treating patients, right? And usually we sort of look for clinical triggers, right? We look for very high platelet count, or we look for neurological symptoms, or we look for something that drives us to sort of intervene, right? I think there's quite a bit of data now to say that if you have JAK2 as your sole mutation, if you're homozygous for JAK2, that you have a good chance of responding well to interferon at the molecular level. And so in my mind, that's sort of, if there's a clinical indication, I feel very comfortable initiating interferon in that situation. Of course, the question as to whether that has the capacity to modify disease in the long term, I don't know that we have data to support doing that. I think when these events, these transformation events happen, they tend to occur much further down, right, the course of the disease, when the patient has acquired more mutations and has undergone genetic and clonal evolution, and interferon is less likely to be effective in that situation, right? We know that there's certain mutations that appear to be associated with resistance. We found DNMT3A in our study, and there's other studies to do that. So, clearly JAK2 versus CALR mutant MPN, it's a much more inflammatory disease. And that may contribute to some of these, as we talked about, cell extrinsic drivers of progression or, evolution. I think, interferon, I think if you're using it, I do think it makes sense to sort of intervene earlier when, if there's particularly if it's a JAK2 mutation, particularly if it's a sole mutation, particularly if it's a young person, and particularly if you have a sort of supportive clinical need to do that. That's kind of my approach in terms of treating these diseases. Don't know if that answers your question.
Yeah, it's still a big dilemma because it's not an innocuous drug.
No, absolutely.
And I think the question is, it's nice to see the VAF drop, but does that correlate with clinical outcomes?
Right, right. And I mean, this is again why we need more studies. We need studies that are prospective. We need studies that understand sort of the, cell intrinsic molecular genetic drivers of progression, as well as the other components, microenvironmental, inflammatory, germline, all of the rest. But I think, hopefully the MPN progression network will help address this, but we certainly an area that we need more studies. Now that we have more comprehensive, molecular genetics on patients earlier in their disease course, I think that's going to be very helpful as we follow these cohorts of patients prospectively and really start to, pull out kind of what are the drivers of different outcomes in these diseases. Much like I tried to give some examples of that very nice study from Jean-Jacques Kalajian's group, trying to do that in the context of splenic vein thrombosis. I think we'll see more and more examples of this linking genetics to different outcomes. But prospective studies, I think, are the way to go, obviously, yeah.
Thanks. Thank you for that answer.
All right, guys, I'm getting word it's time to go to commercial. So everyone take a break and have great discussion, guys. Talk to you all soon, and we'll resume shortly.